let's talk about our objectives. So I wanted to help everyone understand the increasing incidence of NAS or NOWS, so neonatal abstinence syndrome, but more specifically neonatal opioid withdrawal syndrome. Um, and then talk about the symptoms and clinical manifestations that we may see, determine the functional impact specifically using Eat, Sleep, Console, and then kind of compare and contrast the traditional Finnegan type systems versus Eat, Sleep, Console assessments. You've all heard anytime you're looking in the news, pretty much you're seeing headlines about this. Um, you will see my soapbox down here where I crossed off addicted because babies, again, are not addicted. That's addiction's a series of behaviors. So we should not use that term for babies. But you see this pretty much everywhere you look. And I think it's kind of interesting to look at what's happened, over the 7 years from 2010 to 2017. This is actually just the one on the left is in 2017, maternal opioid related diagnoses at delivery. So per 1,000 delivery hospitalizations. You can see in California, we have a relatively low rate. It's not as low as Nebraska, which is the lowest, or Vermont, which is definitely the highest. But you can see, here the percent change in opioid related diagnoses from 2010 to 2017. We're not on the lowest end here. We have had a significant increase. And in the US, on average, it's been about 131% increase from, in those 7 years. So then looking at NAS or NOWS, what's happening and what's changed. So again, we still have a relatively low rate. Again, Nebraska is the lowest and West Virginia is the highest for NOWS. But there's been an 82% increase in NOWS diagnoses during this time. So you can see that California has been, pretty much on par with that increase. So self-reported data from pregnant people showed that about 7% of women who were pregnant reported using prescription opioid pain relievers during their pregnancy. And 1 in 5 of those reported misuse of prescription opioids. So, getting them from a non-healthcare source or using them for a reason other than to relieve pain. And then, or using them, in terms of a different frequency to relieve pain. And then the number of women with opioid-related diagnoses, as we talked about, has increased from 131% from 2010 to 2017. So what do we see in the baby? This is pretty common for a lot of us and was highlighted in the case presentation as well. So that CNS irritability is the hallmark that we're seeing is really high-pitched, irritable cries. They have disrupted, difficult sleep, a lot of tremors, that increased muscle tone or hypertonicity, that really hyperactive more. As soon as you unwrap them, you just see them sort of startle and kind of doesn't settle as quickly. Sometimes they can have seizures. And then they can have things like GI dysfunction. So a lot of difficulty feeding and transferring milk, sometimes vomiting or loose watery stools. And then you can see that autonomic nervous system piece where they have the sweating, fevers, yawning or sneezing, increased respiratory rate, nasal stuffiness. And then they can even have failure to thrive or poor weight gain. And I think, as we mentioned too, that skin excoriation that we can sometimes see that was noted on that baby's heels, that's a hallmark. So sometimes people will say, oh, the butt is very excoriated, right? They have a diaper rash. That is not the skin excoriation we're talking about. That is specifically caused from the loose, watery stools. We're talking about, like this writhing. And so then they have in their axillae or their groin or their heels, right? They have anywhere they've made contact and they're just kind of moving around. They have that excoriation. So you can see that. And I just wanted to highlight that seizures are rare, but they have been noted, and they're noted among all sort of NAS, not specifically just NOWS, but they can be caused by opioid use as well. So the traditional approach has generally been to, use a scoring system. So there's different scoring systems. The most commonly used one is the modified Finnegan. It's a tool that can be helpful, but I think it's really looking at a lot of different factors, and there's a lot of inter-observer variability because there's a lot of subjectivity to a lot of these things. So they measure the severity of symptoms, and oftentimes they're used as a tool to initiate, escalate, and wean pharmacotherapies. So there's good evidence, as there is in a lot of things, that having some sort of protocol can be really helpful. So it can be helpful to decrease the hospitalization time. It can be helpful to decrease or minimize the pharmacotherapy provided. And it's just, provides more systematic care. This is a little blurry and not intended for you to read it directly. This is just the modified Finnegan, so I just wanted to put it here so you could see it and just see all of the points that we're looking at here. So it's got a 21-point scoring system. It's, major kind of limitations are that it's not applicable to babies less than 37 weeks. And for babies that were having really prolonged opioid withdrawal syndrome symptoms, they could go on until they were a month or more, but this is really not meant for babies that are over 30 days old. So that kind of limits its generalizability, especially when many babies may be born slightly preterm as well. And then the goal would be to have them scored, within 3 to 4 hours of birth and continue every, 3 to 4 hours thereafter. And then if you were using this system, you should be scoring the infant kind of at the time of feeds and looking back to the preceding interval. You shouldn't be doing it just when you disturb the baby. But you can imagine, what I consider mild or moderate might be different than what you do. So that adds to the subjectivity, increased muscle tone, right? If I say that this baby's modeled, but they've been exposed for a while, you might just say, oh, but they've been exposed. I kind of expected them to be a little bit modeled like a lot of babies are, right? Breast milk stools are often very loose, kind of seedy stools. Would you call that loose? You might not, someone else might. So, all of these things, and what's projectile vomiting, right? So there's just a lot of subjectivity around these things. Even the things like sleeping may be a little bit challenging in a NICU or hospital setting if, you have multiple infants that you're taking care of at one point in time, because you may not realize that that baby actually slept a little bit longer. You may have that kind of hospital time warp that happens. So this is the eat, sleep, console approach, really just asking, can the infant, eat an appropriate amount? So they say 1 or greater ounces at a time, or breastfeed well. Of course, if this were an older baby, you might want them to eat a little bit more than that, but can they eat an appropriate amount at the beginning? Can they sleep at least an hour between feeds? And then can they be consoled within 10 minutes? And the really important thing to remember is not, can they console themselves, right? This is not looking at, if you lay them down, do they console themselves and fall asleep? This is really looking at, if I pat and shush and hold them and sway them and rock them and feed them or whatever they need, can they then be consoled within 10 minutes? And if they're able to do all of those things, then they're really well managed, right? They're doing baby things, and we want them to do baby things. So we feel like that they're well managed. But if they're unable to do those things, then we need to make sure that we're optimizing non-pharmacologic interventions. So again, couplet care is perfect for this, right? Parental presence, skin to skin, holding them close, feeding them on demand, keeping them warm and swaddling in a low stimulation environment. That is perfect. If despite all those things, their symptoms are not improved and they're having difficulty eating, sleeping, or consoling, then you consider starting morphine. And that has changed a little bit over time, where now the recommendation is, instead of starting scheduled morphine, we're really going more for PRN dosing. So comparing and contrasting Finnegan and Eat, Sleep, Console. With Finnegan, the goal is really just to suppress signs of withdrawal, right? To suppress the number, to treat the number, and ensure you provide some supportive care and you feed them on demand. But really, the goal is to just sort of treat that number, get them out of here when they're ready. But family might be surprised by their withdrawal symptoms. Staff, and this is, I think, more a shift in just neonatal care over time, but the staff really is sort of like, oh, we'll take care of the baby, right? This is more true 10 years ago than I think it is now. There's a lot more family centered care and people really pushing to um, have families active in the care of their babies and to learn and do more for caring for their babies. So I think that's just a little bit better than it used to be, but that was something we definitely saw previously with Finnegan. And now with Eat, Sleep, Console, we're really trying to prepare families for withdrawal signs to know what they may see and what they can do about them. Really treating the infant, so making sure that they're functioning like a normal infant. Goal is really buttoning up that supportive care, making sure that we've optimized that. They shouldn't have a feeding schedule. Again, this is why they shouldn't come to the NICU if at all possible. I understand like your baby had to come to the NICU, Dr. Tiara, because of hypoglycemia and respiratory distress. That happens. And that can be challenging when they do. But if there's any leeway to get them back, we also don't do medications in our newborn nursery at this point. I have hopes and visions that one day we will. Um, but that would have limited our ability to keep this baby in our newborn nursery as well. So we would have done nothing different. But if at all possible, keep them in a couplet care environment, because then you really are feeding on demand, having all of that skin to skin. And we're really working to coach parents to do the care. I suspect most of you have, seen or used Eat, Sleep, Console, so I don't necessarily need to tell you how better it is. But when Yale was doing this as part of their quality improvement project, where they implemented Eat, Sleep, Console, they found that they went from 100% of babies admitted to the NICU to 20%. They started admitting them, more if they needed more support to, or a longer hospitalization. They started admitting them to the pediatric unit instead of the NICU. Their average length of stay moved from 22 days to 6 days. And again, I want to highlight that the tricky part about this is these are methadone exposed babies. This is not all comers with opioid exposure, because again, a baby that got fentanyl exposure in utero where mom was, had opioid use disorder, using fentanyl frequently, that baby is going to be very different. So this is not completely, they're a little bit apples and oranges. This is talking specifically about methadone exposed babies. And 98% of them were previously treated with methadone. In their instance, we would use morphine at our institution, but that was decreased down to 14%, which is great. And then more babies were going to the breast, which is wonderful as well. So that it increased from 20% to 45%. And then obviously it costs less too, right? They're staying for less time. They're not needing as many medications. They're not needing NICU. They're getting more breast milk. So all of those things are costing less. So the cost went from an average of about $44,000, almost $45,000, to about $10,000. And then if you needed to be convinced a little bit more about how cool Eat, Sleep, Console can be, and also for the naysayers that have said, well, then of course they're just going to leave earlier, but then they're going to get readmitted, right? This really set out to look for that. So this was published in the New England Journal of Medicine. It was a cluster randomized trial at 26 hospitals where they were doing Finnegan initially, and then they started to transition, and they had a transition period where they moved from Finnegan to Eat, Sleep, Console. So the staff was trained and they had materials that were presented during that time. So everyone was ready to roll out Eat, Sleep, Console at the different hospitals. And I didn't include this slide, but they kind of wedged it out. So each of the hospitals, there are about 3 in each group. And so they sort of slowly and incrementally moved to all hospitals using Eat, Sleep, Console. And then they looked at their primary outcome was birth, time from birth to hospital, discharge readiness. So I think that was fair, because we all have had babies who have had to stay longer because they're looking at safe plans of care for discharge. So this is specifically looking at, not a social discharge, right? It's looking at when were they ready to go home. And then they looked at a composite safety outcome as well, which was assessed up until 3 months of age, which was looking at um, during their hospital stay, did they have non-accidental trauma or death? Did they have any unscheduled healthcare visits or readmissions to the hospitals? Looking at those sorts of safety markers, and they were successfully able to decrease their mean time until readiness for discharge from about 15 days to about 8. And then their percent receiving pharmacotherapy went from about 54 to about 20%. And then the total opioid dose also went down as well. So it used to be about 6.9 mgs per kg and went down to about 5.3 for those receiving medications. And then direct breastfeeding went up as well. So 19 to about 30, 33% or so. So all very positive outcomes. So I think, this shows us, and then the safety outcomes, there was no difference. I probably should have highlighted that as well, but there was no difference in safety outcomes. So 15.5, in safety outcomes at 3 months of age in the usual group, and 16, but the relative risk crossed ones. There was no statistically significant differences in that. So this is really reassuring, I think, to tell us that this is not creating worse outcomes on the back end. So again, just a reminder of what the Eat, Sleep, Console approach looks like. I want to give the caveats that I guess I should back up and give one caveat, that the way that we ask this in our charting and the way many hospitals ask it, because the toolkit was developed in this way, they say, does the infant have difficulty eating, sleeping, or consoling? So a yes answer is actually problematic. So it's saying that the baby's having issues with eating, sleeping, or consoling due to NAS. So my caveats for Eat, Sleep, Console are that we should really pay attention to make sure that these are not issues not related to non-opioid factors, right? So we want to make sure that we think that this is due to NAS or NOWS, not due to prematurity for poor feeding, because that's a very common one I see in our NICU, because we have babies that are, say, 34, 35 weeks. They're not great feeders, but they feed the same as you might expect another 34 or 35 weeker to do. So that's kind of on par and not related to NAS or NOWS. As many of you have seen with NAS or NOWS, those babies often are, in terms of the poor feeding piece, they often appear voracious, right? They appear like they are struggling to find the nipple. They're wanting to suck on everything, but then they actually just don't, they don't transfer well. They're really poorly coordinated. So that's very different than the preterm baby who doesn't yet show cues, that doesn't yet have suck, swallow, breathe coordination, that doesn't transfer well initially because they're just not strong enough to do so. So keep in mind, we don't want to indicate, yes, they're having difficulty with eating if they're premature and acting like a preterm baby. If they have a little bit of spittiness, like maybe they're having some spit up of amniotic fluid in their first 24 hours, or they have an anatomic, size issue where the baby's mouth is too small to fit on the breast and they're not feeding well that way. Again, we should not count that against them, because we wouldn't want to medicate them for those problems, right? That's not going to have any improvement in their symptoms. And then we can see, and this may have contributed to some of the symptoms that your patient was having, poor sleeping with nicotine withdrawal in the first 24 hours. And sometimes even SSRIs, we have that, poor neonatal adaptation. And then we can see some cluster feeding. So we definitely should not count that against them if they're awake for a while trying to cluster feed on that second day of life. If they are interrupted to get their newborn screen done or to get their hearing screen, right? And that's unfair to count that against them. And then if they're having difficulty consoling, but we just did a circumcision or caused some pain in some other way, we need to make sure we're not counting that against these babies. So this is what we do in our newborn nursery. Is we have, babies that are at risk, meaning they had opioid exposure in utero. We begin assessments within 4 hours of birth, and we assess every 3 to 4 hours thereafter. Everyone should have these things in the middle done. Optimize non-pharmacologic treatment, so minimizing stimuli, dimming the lights, minimizing the noise. So kick out all unnecessary people, do as much skin to skin as possible, swaddle the baby gently, and then feeding them on demand, ideally with breastfeeding unless there's some reason for contraindication. And then if they continue to have no responses, meaning they don't have issues eating, sleeping, or consoling, we just think about how long they need to be here based on the substance half-life. So long half-lives are things like buprenorphine or methadone. And actually, this should probably say 4 days because for bup, the AAP had come out with something not too long ago that said we can discharge after 4 days. Christine, you raised your hand.
So I have a question.
Yeah.
Do you get your lactation? Do you have lactation that's dedicated for these types of babies, one, and have them intervene and help with that breastfeeding immediately? And the other question is that what about the other ancillary services like PT and OT? Since they're not in the NICU, will they go out to the floors and work with them?
Yeah, so that's a great question. So yes, we should have, as with any dyad that wants to breastfeed, we should have lactation support available and ready. And depending on the comfort of staff, otherwise, right, in assessing latch and assessing, I feel like NICU staff, my experience has been generally NICU staff feel less comfortable assessing that than labor and delivery staff do. So if they're in couplet care, I think that people are much better at assessing that and then pulling in help sooner. I would say our priority should be in a NICU setting, should be getting that baby with that mom and having lactation see them as soon as possible because there may be some subtle things that can be optimized that people aren't necessarily as aware of because we just don't have as much exposure or experience and teaching around breastfeeding directly. Many of our babies can't, right? So that's the other reason. So yeah, I think that that's great. We certainly sometimes do have OT and PT work with these patients, and we do have pediatric PT and OT that can work with babies on the floor. They generally, I would say, wouldn't necessarily be working with them in newborn nursery, but if there were concerns, they absolutely could. But if we have a baby that stays, for instance, like Dr. Tiara's case, where they're on medications for a period of time, sometimes if we're quite full and pediatric wards has space, which I actually think it's a better place to be, we'll send those babies to the peds floor because then they can be essentially in couplet care again, and they can get any kind of services over there as well. So for long half-life medications, we would say 4 to 7 days, really. So I'll make sure to fix that for later, but 4 to 7 days. And then if they're having stable eat, sleep, console assessments, then they can go home. If it's a very short-acting medication like an oxycodone, they could stay for 72 hours and be monitored. And then if they're having issues with eating, sleeping, or consoling, so they're having yes responses to these questions, then we would want to optimize non-pharmacologic care. And if that has been optimized, then we want to initiate a team huddle to sort of evaluate, is there anything else that could be causing this? And even something as silly as a hair tourniquet, right? That could be causing inconsolability, and that wouldn't be due to NAS, right? So having a careful look at the baby and then also making sure that we've optimized the environment. And then if needed at our institution, we would transfer to the NICU for ongoing care and pharmacotherapy. But again, keep in mind that then you are not optimizing your non-pharmacologic care by taking them away from their parent. So it should be done very thoughtfully. And discharge criteria, we would want to monitor them, as I said, make sure that they stay for the minimum amount of time just based on their length of opioid or sort of duration of treatment, half-life, that's the word I'm looking for, half-life of the medication, thank you. And then some babies may have delayed presentations. I feel like it was maybe a little more than a year ago, we had a baby who came through the ED that had been discharged home from newborn nursery, had stayed the appropriate number of days, and then just was having some inconsolability difficulty, managing at home. They brought the baby in. The baby had one dose of morphine and never needed another one and was able to be observed for a couple days and discharged home. So we can sometimes see this delayed presentation, but it's relatively uncommon. And then just normal things you discharge home for, right? The baby is not showing major signs of withdrawal, but is otherwise feeding well, sleeping well. The gaining weight, I put plus minus, right? Because some babies may not be gaining weight if they're only here for 3 to 4 days, but at minimum, you want to make sure their weight is not too too long or too excessive of a loss. And then obviously we always want to have a safe plan of care for home. So if the home environment is deemed safe, otherwise foster or some other safe discharge plan with kin care. And then these are some good resources for Sac County. So I think I looked them back up and I changed a couple because this community nursing used to be slightly different. It was called something slightly different, but these are great resources. Your social workers have access to these. If you're not in Sacramento County, just go to your Department of Health's webpage and sort of see for your county and see what options there are. But pretty common to have nurse family partnerships and Black infant health. They may also have the African American perinatal health program in your county. And then there's probably some sort of community nursing where there's in-home health and support services for individuals who qualify. So keep that in mind for your patients.